Hello, my name is Maureen Corcoran, and we're here today to talk with you about the innovations and coming changes in the Department of Medicaid. And I'm pleased today to be joined by several of my colleagues, Dr. Wharton, Tracy Archibald, Sean Eckerd, and Stephen Alexander. You'll hear from them today as we go along as well. Next slide. We're going to talk to you a little bit about the overview of the department or the pharmacy program. Then we're going to talk with you a little bit about the economic impact of COVID on our current healthcare services and systems, a little bit specifically about COVID and testing and the role of pharmacists. We'll also then be giving you updates on a variety of the Department of Medicaid initiatives that specifically affect pharmacists. And then very specifically, some discussion about pharmacists as providers, some of the changes that are coming there. And finally, we'll talk about the Medicaid procurement, Medicaid Reimagined, and some of the changes that will be occurring in the program, again, with a little more of an emphasis on how it affects you and pharmacies and pharmacists across Ohio. So first, for those of you that aren't as familiar, Ohio Medicaid serves approximately 3 million Ohioans, and more and more these days during COVID, that about 90% of all individuals on Medicaid are in what we describe as a mandatory managed care relationship. They choose among any one of 5 managed care plans that all serve throughout the state. And particularly as it relates to pharmacy, our pharmacy spending is about $3.5 billion per year, with about 50 million prescriptions. We participate in both the federal mandatory rebate program as well as the supplemental rebate program. Next slide. Next slide. I want to talk just briefly about this, as it will impact our work and our work with you over the next number of months, and in particular as we go into the next budget. So as you know, we have a 2-year budget in Ohio. The current budget was adopted last July. So this July, we began the second year of the 2-year biennium. And we already are doing the work to plan for the next biennium. Our budget, the governor's budget, will be introduced early next year. We go through then a process of several months, resulting in a budget that's adopted by the General Assembly by midnight on June 30. Currently, because of the situation with COVID, our state overall revenue is projected to be $2.4 billion short for this year, for state fiscal 21. And we're looking at an even more difficult budget situation for the future. So what's important about that is that we are in the process of making some reassessment of some of the decisions that we've made as it relates to the budget. And so I wanted to just kind of mention that and remind you, or remind us in this discussion, that, unlike, say, at the federal level, states, Ohio has a constitutional obligation to have a balanced budget. And obviously, what was really a very positive economic situation in Ohio prior to the pandemic has now taken a very, very significant hit. And this is forcing us to adjust course. Late last fiscal year, so in June, we made a series of rather rapid and significant cuts in both our administrative capacity as well as in our payments to managed care plans. We also now are in the process of reviewing the last budget decisions and reassessing them both for this current fiscal year as well as in preparation for the next budget year. So in particular, there were about a dozen and a half or so major initiatives in the budget that were adopted that we're relooking at, and they include a variety of the governor's priorities around mothers and babies. It includes the discussion about the tiered dispensing fee. We're looking at a variety of our initiatives as it relates to postpartum women, our substance use disorder waiver, and various new services and enhancements that we had intended as a part of our both the budget adoption and some of our enhancements to bring online. That assessment is underway and is in part dependent upon what happens with the federal discussions, where, as you know, there is active discussion about the need for states to have additional funding. We'll continue to be in touch with you and with those in your associations that represent you to keep them apprised. Certainly, we know that looking toward the next budgets, also there will be a need for significant attention to cost containment items. Next slide. You've just heard earlier from Mark Hamlin, who talked with you about the administration's overall focus on COVID testing and some of the work that cuts really across all populations and all of the state's various strategies for testing. What we'd like to do now is talk with you a little bit more specifically as it relates to Medicaid and where Medicaid fits into this larger testing strategy. So next slide, and I'm going to turn it over to Sean Eckerd.
Hi, this is Sean Eckerd. I'm a pharmacologist here at the Ohio Department of Medicaid. And we're going to be going over COVID-19, specifically within the pharmacy benefit. So we're going to start by giving you an overview of some general pharmacy actions that we've taken. And we've taken these actions very quickly at the outset of the pandemic to ensure that our members continue to have access to their pharmacy benefit and necessary medications. One of those items is we've eliminated network restrictions for our managed care members so that they can really get access to pharmacy benefits at any pharmacy that is in the program. We've also authorized medication refills in the event of an emergency without a prescription, as is authorized under Ohio state law. We relaxed the refill threshold for medications to 50% to ensure that members continue to have access to their medications should they be quarantined or infected with the virus and not able to leave their home. We also waived copays for all medications, regardless of whether the medication is used to treat COVID-19 or not. That was especially important during the pandemic as the economic impacts of the pandemic were significant. We also allowed pharmacy providers to dispense and be reimbursed for many over-the-counter medications without a prescription. And then we've also done other things as well, such as allowing acute opioid refills up to 14 days when necessary, as well as waiving the signature requirement at prescription pickup to ensure that members don't have to touch shared equipment unnecessarily. Next slide. Next, I'll talk about COVID specimen collection, and this has really been an area of focus for the department. On June 29th, we announced that we would be reimbursing pharmacies for COVID specimen collection. And this is, it really allows pharmacies to collect specimens either by staff members or by a medically supervised process where patients can self-swab, for example, through a drive-through and actually submit the specimen that way. The first phase of this, really, we focused on specimen collection due to the availability of testing equipment as well as lab bandwidth issues as well. At this time, we didn't have a lot of point of care testing availability, and we still don't within the market. And so this was really a priority for us in the Medicaid program. Claims are submitted through existing billing logic, and we utilize the vaccine billing logic, specifically with the MA professional service code. Reimbursement works very similarly to vaccines in that you're paid the incentive payment for that professional service code. We are paying or reimbursing $23.46, which is the Medicare rate for the equivalent HCPCS code, which is G2023. And the specimen collection initiative really does support the DeWine administration's goal of increasing access to testing for all of our members and for the state. Next slide. Next, we move to point of care testing, and this is an area of focus for us as well as we move into the autumn months. Point of care testing is likely to be more of a focus as the machines become more readily available, as well as the testing kits themselves. There's already several FDA authorized, and these are authorized under emergency use authorizations. There's already at least 6 as of last check, 4 of which are molecular tests, 2 of which are antigen tests. And we do expect the availability of these products to become more widespread through the fall. And this is really determined by some market intelligence, as well as the manufacturers themselves providing this information. So we do expect the availability of this equipment to improve. And we are working right now to develop billing and reimbursement methodologies to best support our members, to best increase access to testing, and also reimburse in a very fair way to the providers that are performing the testing. We do anticipate that reimbursement for this would be very similar to the vaccine methodology as well, through the use of professional service codes, so that these can be billed through existing pharmacy billing logic. Next slide. Next are vaccines, and vaccines are really going to be a very, very important focus, maybe not this fall, but certainly early next year, optimistically speaking. There are several vaccine candidates out on the market. There's over 100 of them. At last count, it was about 180. And 8 of those are in late phase testing, so in phase 3 testing. And these vaccines are very interesting because there really is the gamut of vaccine technology that is being developed. We have genetic vaccines, specifically through the use of messenger RNA. We have viral vector vaccines where they're using adenoviruses and AAVs, protein-based viruses, and then more traditional inactivated whole virus technologies. And these technologies, you know, they all are very different, and they are very different in the way that they work, and they're also very different in the way that they're administered, and specifically the need for booster doses. And what we're seeing right now is most of the late stage candidates are actually going to require 2 doses over that first 14 to 28 days. Certainly there are candidates that only require 1 dose. However, most at this point are requiring 2 doses of vaccines. And this is going to be really one of the most widespread public health initiatives of likely our lifetime in vaccinating a population of over 300 million people possibly, not just with 1 dose of vaccine, but with 2. And so we anticipate that pharmacists are really going to be very important partners, not only in the administration of that vaccine, but also in the patient education component of this as well. In that patients really are going to have a lot of questions about these vaccines. They do utilize some new technologies in some cases. And so pharmacists, we anticipate, are going to be on the forefront of this initiative. And we are currently and very actively monitoring the vaccine landscape. And when we have more information to convey, we will certainly do so. And that could be information regarding supply, distribution of the vaccine, as well as reimbursement of the vaccine. Next slide.
Great, thank you, Sean. I want to turn it over now to Stephen Alexander to give you just a brief update on a number of the initiatives that the department's been engaged in the area of pharmacy. Stephen?
Hi there, my name is Stephen Alexander. I'm a legislative liaison and policy analyst for the Department of Medicaid, and just wanted to talk to you a little bit about some of the changes that we have made to date. Many of you know that spread pricing has been banned throughout the care management system, and managed care plans and their PBMs can no longer use it, instead requiring a pass-through or transparent model to be utilized instead. Additionally, late last year, ODM released a pharmacy dashboard that is updated quarterly that offers more insight, that is public facing into a lot of the data aggregately that is used, and shed some light on what's going on in the pharmacy benefit throughout the Medicaid program. The Unified Preferred Drug List was released this year, and the managed care plans now use a common preferred drug list instead of having their own. And this has had the impact of prohibiting the practice of the PBMs allowing or being allowed to negotiate supplemental rebates directly with the managed care plans. That's no longer a function that they have. Additionally, it has alleviated a lot of the administrative burden for the providers, both pharmacists and prescribers, in order to let them only learn one preferred drug list instead of 5 or 6. And Medicaid is also an active member on the Drug Transparency and Affordability Council, which is looking at, it was created in the most recent budget, and it is looking at the entire prescription drug supply chain to help lower costs and improve quality, not just in the Medicaid program, but throughout the entire healthcare system. Next slide. On this slide, we have a lot of changes that were made to the managed care contracts in July of 2019. And they were all looked at from the perspective of what can we do quickly to bring more transparency, more accountability into Medicaid's pharmacy program, specifically within managed care. Never thinking that this would be the only step we take, but rather just a first step. So you'll hear a little bit more about where we're going, but some of the things that were changed back in 2019 in July include a lot of changes related to the specialty drug space. ODM is exerting a lot more authority in that space, not just over the contracts or not just over the networks that the PBMs utilize, but also in the drugs themselves that the PBMs consider to be specialty. Additionally, there are strengthened measures for compliance audits, greater ability for ODM to acquire and require that the managed care plans and their PBMs give us data that we previously didn't have access to. And a lot more coordination is going on with the Auditor of State, requiring the plans to obtain and transmit that data over to us into the Auditor of State so that we can have a more complete picture over what the PBMs are doing, what their encounter data looks like, things that previously didn't exist, we now have access to. And again, this is just a step in the right direction, but you'll hear a little bit more about what is yet to come. Next slide. Okay, I think back over to you, Director.
Thanks, Stephen. We're going to talk in a little bit about our changes in the managed care procurement arena, but first we want to talk with you about the work that's underway to establish pharmacists as providers. And I'm going to turn it over to Tracy Archibald, the director of our pharmacy program.
Thank you, Director. Next slide, please. So we have many objectives for pharmacy transformation for implementing pharmacists as providers. First, practice transformation. So historically, pharmacists have been underutilized in the healthcare system. I don't think we need to tell that crowd this, but pharmacists are trained in many clinical services beyond just dispensing medications. And traditionally, our healthcare system has mainly incentivized pharmacists for dispensing medications and not necessarily taking advantage of full potential of the clinical services that pharmacists are able to provide. So Medicaid is moving in the direction of paying pharmacists for their clinical expertise. Next slide. So incentivizing integrated care. Pharmacists are currently very much siloed from the rest of the healthcare system, but we really would envision that pharmacists are working alongside other healthcare providers. We have been working to incentivize broader inclusion of pharmacists into the healthcare team, such as our comprehensive primary care or CPC practices, where you have multiple provider types working under the same roof. Requiring MTM programs or medication therapy management programs for our managed care, and then provider status, which is really the next step. So ODM envisions greater participation for pharmacists in team-based care as really the drug experts that we are. Next slide. And then it's fiscally sustainable. So that, greater pharmacist involvement really will help to provide long-term value, healthier outcomes for our members. The current budget situation due to COVID and everything the director mentioned earlier in the presentation makes it very difficult to implement any new policy initiatives, but we are committed to having pharmacists as providers as a top priority for the department. Initially, the program design will be crafted to carefully maximize value on a limited budget, so working kind of within our means at this time. But we're going to continue to work with pharmacists and OPA on future changes even after implementation. So it's a little bit of a stepwise approach, especially given the current environment that we're in. Next slide. So for implementation schedule, we released the draft rule for public comment on June 29th. And then in November, there will be various provider training webinars. We will need to make changes to our Medicaid information technology system that will allow pharmacists to enroll individually, which is something that is currently not being done. So we want to make sure that pharmacists are educated on how to use those systems. Our targeted go live date will be January 15th of 2021. And we will be scheduling a series of stakeholder meetings in the near future to discuss the rule package with pharmacists and the associations prior to filing with the Joint Committee of Rule Review, JCAR. Next slide.
Great. Thank you, Tracy.
Back over to the director. Thank you.
Thank you. Okay, next slide. I want to talk with you a little bit about where we're going with the overall managed care changes in Ohio. As I mentioned, more than 90% of our members are in a mandatory managed care environment. The current program is more than $28 billion, including the $3.5 billion for pharmacy and medications. And so really, even beginning before January of 19, you'll see there the first little leg says pharmacy benefit managers lack accountability and oversight. As you know, this was an issue that really began more than a year in advance of this. So early in 18, there began to be the focus on the role of PBMs, not only in Ohio, but across the country. And that set the stage for some of the changes in this particular area. Over the course then of the last 15, 18 months, we've had a listening tour all over the state. We've had several requests for information in various components of the program. We've now had several procurements that have been initiated and have, in each case, have offered opportunity for potential vendors or those who are affected by it to come in and meet with us and talk with us. So even in particular, because of some of the COVID changes, we've even added more steps or more options to enable people to continue to talk to us, even though we're all kind of limited in our ability to move around these days. So the PBM accountability issues, that was obviously a big focus in Ohio as well as nationally. What we also heard, though, pretty uniformly in the listening tour that was with consumers and community members, as well as with targeted professional groups and meetings, was that providers across the board felt that the administrative requirements were unnecessarily duplicative, and particularly because there were multiple requirements that varied from plan to plan, that it was confusing and it took up time that was taking time away from serving consumers. We also heard quite a bit about gaps and inconsistency in data, making it very difficult across the system, whether between the department and the managed care plans or in work with constituencies, stakeholders, and others, that it was very difficult to bring the kind of data and visibility to the conversations about the program in the various components. We also heard quite a bit about both children and adults, particularly those with more complex needs, where there are just really heightened needs for intensive coordination and the ability to assist them in interacting with the various components of the healthcare system. So that was an area of significant focus that we heard not only from practitioners, physicians, care, other of our healthcare provider partners, behavioral health, but also from families themselves. We also heard that member care was fragmented and inconsistent in the experience and the quality. We heard a lot of very good and very positive stories about relationships and work that our current partners had done with members, but we also heard still a little bit too much examples where individuals really needed to experience a higher level of satisfaction with their services. So as a result of all that and giving us all this input, the governor has really challenged us to ensure that Ohioans get the best value for the highest quality of services and care. And so that is a key guiding principle to us in this work. Next slide. These then is a good summary of the goals that we bring to reimagining Ohio Medicaid through this process of design and reprocurement. Most importantly, and you can see from the logo in the upper left-hand corner, that our focus is on the individual, to put the individual at the center of our framework, to emphasize a personalized care experience, and in particular, given this population, to focus and target our energy around improving wellness and health outcomes, given the disparity, not only because of the economic situation, the socioeconomic considerations of individuals served by our program, but also those that are because of racial inequities and differential racial impact across our healthcare system. Our third goal is to support providers in better care, to limit or eliminate some of the additional confusion and duplicative requirements that I mentioned just a moment ago. We have a specific set of focused priorities around improving care coordination for adults and children. And then, as you've heard through a lot of our presentations so far, to improve program transparency and accountability really across the board. Next slide. So this is then a high-level summary of Ohio's Reimagined Medicaid program. What you see on the right are 5 major components or pieces of the puzzle. Now today, as you know, we procure a single comprehensive package of services from the 5 managed care plans who operate in our Medicaid managed care program. So that package or that accountability is for medications, hospitalization, all healthcare services, services to children and adults, really across the board. This represents a significant step towards the new generation of managed care. So, some of our folks have used the analogy of the iPhone, which we all know what that was like when it first came out. And then it didn't take very long before people wanted a camera on both sides and they wanted a little bigger phone and new kinds of applications. And so we know how the different generations of phones have gone since then. And this is how we view the next generation of managed care as well. So there are some specialized components that will be individually or separately administered, such as the single pharmacy benefit manager. We're going to talk a little bit more about that in a moment. We also will have a specialized managed care component for children, a small subset of children with very intensive behavioral health needs. we are implementing what's referred to as a fiscal intermediary, a single front door for all claims that will provide a standard format, a standard set of coding. It will largely eliminate the need for providers to have to utilize or pay for their own clearinghouse in order to interact with Ohio Medicaid, in that it'll be kind of like a clearinghouse on steroids that'll provide a single point of intake, and then that electronic information will be transmitted to plans who will continue to do the important components that they do around coordinating care, adjudicating the claims, and some of those other clinical functions. Fourth, and we're going to talk about this in a moment, we're implementing centralized credentialing. One of the things that we heard quite a bit about was that each managed care plan has their own credentialing function, so that an individual doc, or soon to be, in your case, pharmacists who may want to be serving in a variety of, for several of the managed care plans, would have to go through a similar administrative process with each plan. So this is implementing an approach where the credentialing will be done one time, where the requirements will be reviewed, and then those practitioners will be able to negotiate with those managed care plans for services that they want to provide in, depending on what areas of the state they live in. And finally, also reprocuring for our current managed care partners. And so this is really 5 components that make up a whole. Again, all managed care components, the next step of managed care technology and enhancements, but done with some more specialized management and greater transparency. Next slide. Now, in a moment, Dr. Wharton's going to talk with you about a couple of these key components. But as you heard just a few moments ago, in January, we'll be implementing pharmacists as providers credentialing in order to initiate that within the Medicaid program. You'll be using, as you are brought into the program in January, you'll be using our current approach or our current methodology, and then we'll be transitioning the entire program into this new credentialing that Don's going to talk with you about. But it was important to us, and part of the reason that we moved that timeline up to January was based on a lot of the very significant feedback that we got from pharmacists about the desire for us to move more quickly, and wondering why it takes so long. And so we have made that a priority, kind of pulled it out, put it at the beginning of the year, and then this new procedure will take place later in the second quarter. So Don, I'll turn it over to you.
Hello, I'm Dr. Don Wharton. I'm the Assistant Medical Director at Medicaid. And what I'd like to do today is just go a little bit deeper into a couple of the Medicaid Reimagined elements that most impact pharmacists. And certainly the first one that I'm going to talk about today is the centralized credentialing. As you can see, Medicaid has hired a CVO, a credentials verification organization, to assist us in collecting primary source verification data. This has to do with licensing, certifications, backgrounds, and so forth, to make sure that we are credentialing the best providers for the care of our members. CMS does require credentialing for providers, including hospitals, physicians, mental health centers, SUD providers, nursing homes, any type of healthcare professional permitted to practice independently under state law, and soon that will include pharmacists. So stay tuned. ODM will make the final determination for Medicaid based make the final determination for Medicaid based on CVO gathered information. So it is our choice. We will have a credentialing committee that is including members of ODM as well as folks from the outside. We are planning on having a pharmacist on that committee, in fact, to help us determine credentialing for individual practitioners. Providers now will only need to enroll once through ODM's new secure portal, easing administrative burdens, reducing cost of providers, where in the past you had to enroll with Medicaid and then with each of the individual managed care organizations. Now, this new credentialing program will begin in March. As stated, we will be enrolling pharmacists prior to this for the Pharmacist as Provider program, as stated by the director. Next slide, please. So this will also impact pharmacists quite a bit. This is the procurement of a single pharmacy benefit manager. Our current structure involves each managed care organization having a relationship with a PBM, which puts ODM one step away from each of those PBMs. And you've heard and you know firsthand, I'm sure, about some past issues that have been realized through this structure, including inadequate data transparency, insufficient state oversight, some misaligned incentives and conflicts of interest that have been noted. Historically, these PBMs have had some uncurbed latitude to determine things like supplemental rebates, who their pharmacy network is, ingredient costs, dispensing fees, specialty drug networks, even the definition of specialty drugs, managed care reimbursement structure, the spread pricing that you've noted. A lot of this went on, and it went on outside of Department of Medicaid's control for a while. We've taken huge steps in fixing that, but as Steve said earlier, a lot of that was temporary. It was a Band-Aid. It was something to get us to where we need to be, and that is where we're moving now. ODM will be transforming itself as far as its pharmacy benefit through a procurement of this single pharmacy benefit manager, and I'm going to pass it back to the director to talk about the process of that procurement. An exciting time. Thank you very much.
Thanks, Dr. Wharton. So I'm going to, as Dr. Wharton mentioned, I'm going to tell you a little bit about the logistics or the particulars. In accordance with the budget bill that was passed last July, the department is required to select a third-party administrator to serve as a single PBM for managed care clients in the Medicaid program. In October of last year, we released a request for information to seek input from any wide variety of stakeholders to give us ideas, suggestions. All of that information was digested, taken into account. Then in November, we conducted interviews with those who responded to the RFI and who wanted to provide more face-to-face information to us, who wanted to discuss certain ideas or to share more information with us. The RFP was posted on July 24th of this year, and we are now in the procurement process, or what is known as the quiet period. During the quiet period and the procurement, any specific information about the procurement has to be communicated only in a public manner so as not to advantage or disadvantage any particular entity. So we're currently working through a series of frequently asked questions, for example, all of which are being posted publicly on the procurement website. I might also just point out that, as you will also see in the language of the budget bill, it contemplates or it recognizes that once we select a provisional procurement, a provisional PBM through the procurement later this year, that there will then be a significant period of time where the readiness process, which is required by CMS, and a series of other policy work will occur. And then ultimately, the transition of individuals to from their current pharmacy arrangement to the new PBM. So while we'll be selecting a vendor later this year, we also know that it will then take a period of readiness and preparation and transition so that all of these procurement components will be operating together and will be coordinated in their implementation. Next slide. So just to sort of summarize or reflect, currently, this is what our managed care program looks like. The department contracts with 6 managed care plans in a full risk managed care contract, which includes prescription medications. Each managed care plan contracts with one or more pharmacy benefit managers or PBAs. And so you can see that there then creates a variety of different relationships, and herein demonstrates a little bit of the difficulty that was described earlier by both Dr. Wharton and Stephen about the difficulty in complete transparency and visibility. Currently, ODM also contracts with a PBA that assists us with the administration of the fee-for-service program, and that is Change Healthcare, who serves as our PBA. Next slide. So this is just to briefly give you a comparison of how the current Ohio Bureau of Workers' Compensation and the Ohio Department of Administrative Services administer pharmacy benefits. And you'll see this is virtually identical to the approach that Ohio Medicaid will be taking. In the case of DAS, they deliver medical coverage through a preferred provider organization. And then, so there are multiple choices or several different choices of the medical benefit provider. And then each of us who are state employees have a single pharmacy benefit manager, a single card for that benefit. Similarly, the Bureau of Workers' Compensation contracts with 11 managed care organizations that do the functions that you see listed there. And then again, similarly, they contract with a single pharmacy benefit manager to administer their program of medications for injured workers. Next slide. So the upshot of all this is that there is a desire in Ohio, a significant desire in Ohio, and through the direction of our legislature, as well as across the country, for greater accountability and transparency in the pharmacy benefit arena. So as you've heard, the pharmacy benefit manager will be contracting directly with ODM. The department will have the ability to require predictable and fair pharmacy reimbursement and pharmacy networks. And those are both things that we've heard quite frequently from pharmacists and from pharmacies across the state. ODM will also have the additional tools to ensure that the pharmacy benefit is aligned to both support integration with clinical services and to provide the transparency that we've discussed. And throughout this new structure, as you learn more about both the PBM and the additional support vendor functions that we'll be procuring, there will be obvious and extensive checks and balances to prevent some of the kinds of conflicts of interest that have plagued the pharmacy benefit management industry. Next slide. We've covered an awful lot of information, and I hope that it's been useful to you. We appreciate the support that we've gotten from OPA in putting together this presentation for you. We look forward to working with you and with Stu Beatty and your providers as pharmacists as provider task force that you have in order to implement this in a way that will be not only administratively least burdensome, but also will give us a strong platform for really maximally utilizing your clinical expertise and your community and local connections that you bring to the healthcare system. So thank you, and we look forward to working with you in the days ahead.